Hello everyone. Welcome to our next episode of Glom Goals. I'm Shri Sharma, a kidney pathologist at Arcana Labs.
And I'm Tiffany Kaza. I'm also a kidney pathologist at Arcana Labs.
And today we would like to welcome Dr. Hastings as our host. And thank you so much for your time, Dr. Hastings, today. Dr. Hastings is a professor at University of Tennessee Health Sciences. She's trained in internal medicine nephrology as well as pediatric nephrology, and she is a program director for the nephrology training program. We are so blessed to have her in our podcast today because it's such a unique situation she is in. She takes care of both pediatric patients, adult patients, and the transition of care between the pediatric and adult. So I'm looking forward for our discussion today. So in the last episode, we went over the technique of the biopsy to make sure we get an adequate biopsy. But still, we have high rate of inadequacies at many centers. And ultimately, as a result of that, nephrologist needs to make some critical judgments, like how to treat a patient when the biopsy results are made on an inadequate biopsy or not that great biopsy. How do you talk to a patient and decide that, okay, I'm going to treat you on the basis of this biopsy report, or we need to do a second biopsy? Those are all very important decisions and discussions. So we would like to talk to Dr. Hastings to see how she handles such scenarios in her day-to-day practice. And it is possible that she might be fortunate that she does not handle or takes care of so many inadequate biopsies, but we would like her point of view that how in a day-to-day life she will advise someone to make a judgment on those scenarios. So we will just jump in, Dr. Hastings. And my first question to you, when you get a biopsy in which the biopsy was not adequate, emotionally, what is going on in your mind when you are looking over such a report?
So, I mean, it's always stressful to get that report when there's concern for adequacy. But my first thought is, can it answer the clinical question? Can this biopsy, is there enough information on this biopsy that I can make treatment decisions? And then, how am I going to discuss this biopsy with patients? And then, ultimately, are we going to need to do a biopsy, or do I have sufficient information to just move on without another biopsy?
So, clinical information wise, Dr. Hastings, what is enough for you? Just the diagnosis part is enough? Like, what are you looking like? What will make that report enough for you?
Can we get a diagnosis from the tissue sample that was submitted? What is there enough background? Can we look and is there some determination about the chronicity of disease based on this biopsy? Is there something in this biopsy that makes me need to intervene? A lot of times we're trying to make decisions about immunosuppression. And immunosuppression is not without risks. And so it's a combination of things. If there are no glomeruli, then you're not going to have probably enough to make a decision. If you've got 6 glomeruli, you might have enough to make a decision. If you've got a healthy background, if there's no tibial atrophy or interstitial fibrosis, you may want to be more aggressive about pressing on with immunosuppression prescriptions versus if you get a kidney biopsy where you still get a lot of, just from the little stuff that they got, there's a lot of fibrosis and atrophy. You may not want to proceed with another biopsy. There may be too much chronicity and there may be a lot of risk for bleeding in that situation.
Yeah, we have found that a lot of our biopsies that we consider inadequate are not entirely non-diagnostic, as you mentioned, but could miss the concurrent disease process or might not have enough glomeruli for scoring systems. And it also affects our ability to do ancillary studies. Um, in your practice, do you find when you get an inadequate biopsy, is this mainly a technical problem, more of a systems problem, or a problem with communication between the radiology, nephrology, pathology? There's multiple players in the kidney biopsy, and what do you see as the largest issue?
I think it's more of a combination of those factors. I am very lucky in the center where I work that we have got great technical expertise. So our radiologists do our biopsies and they generally do a great job with that. If there may be issues where the nephrologist really didn't communicate with the radiologist about the body habitus of this patient. Uh, there may be things where we don't actually communicate the history well to the pathologist. So I don't think there's one specific area. I mean, if we clearly didn't get kidney tissue, then there's obviously a technical problem there. But most of the time, I think it's all those three factors working together to have a negative outcome.
Got it. So, Dr. Hastings, let us dive into the concept of adequacy. Tiffany will tell us on the pathology what we consider adequate. But from the clinical side, is there a concept for you what is adequate? And did that concept evolve over time as you have practiced over years?
I think it definitely did. I think if you go in and you're a fellow and a new faculty member, you're focused on number of Glom, you're focused on, making sure, and even as a fellow, I did biopsies, making sure we get cortex, we're trying to make sure we're using a correct gauge needle. I think as I've kind of advanced in my career, I mean, my focus is more on, do I have enough information to make a diagnosis and to guide treatment decisions? And that is where working with expert pathologists has been incredibly helpful because, I've worked with pathologists and we've worked with Arcana for years where the pathologist has taken a pretty lousy biopsy specimens and been able to kind of work through that and give me the clinical information that I need. I had a patient years ago that had lupus nephritis as a teenager. We didn't get a whole lot of glomeruli, but we were able to go ahead and classify this patient as a Class 4 lupus nephritis and treat her aggressively. She did really well based on the expertise of the pathologist, being able to get some answers from really what would be considered an adequate biopsy specimen.
Mm-hmm.
Yeah, no, I agree. We frequently have small biopsy specimens and just want to try to improve biopsy adequacy because we try to get those answers with the tissue that we have. In our practice, when looking through some of the data in over 100,000 cases, we found that 27% of cases have less than 10 glomeruli that we would consider inadequate. For native biopsies, there's actually no standard right now as far as what biopsy adequacy is. For transplant, it's 10 glomeruli, 2 cores of cortex, and 2 vessels. But if we look at the 10 glomeruli, that's more than a quarter of cases where we don't have that. But that doesn't mean we can't make a diagnosis in a quarter of cases, but don't want to give a suboptimal diagnosis either. Um, Surprisingly, transplant native biopsies, like if you look at all the practices together, we have similar adequacy rates despite the transplant being easier to get to. Peds do a little bit better than adults, and that, as you mentioned, could be due to body habitus, for example. And we also did an analysis of zip codes and found that in healthcare underserved areas, as well as academic medical centers, all have the same issues with biopsy adequacy. So, um, such an important problem to address.
But it is, your studies does provide a lot of help for the nephrologists and our patients.
Because we have to dig deeper, like we have to do paraffin immunofluorescence, we need to do EM from the paraffin tissue. Though the paraffin IF is good, but still there are limitations for paraffin immunofluorescence as well as paraffin EM. So we would like to have all the tissue in appropriate medias from the very beginning we receive it, because we don't know what the diagnosis is going to be. And even when suppose we give the diagnosis, chances of unsampled disease is higher when we don't get an appropriate tissue. Simple example, like in adult patients, you will have like ANCA. I have seen cases even when there are 30 gloms, we might not be able to find a glom with a crescent. And we know that, so this is what I'm talking about, 30 gloms, but sometimes if you have like 6 or 7 gloms, chances of missing are pretty high, right? And we need to make that diagnosis. Like a patient with proteinuria, I need to see that segmental sclerosis. So when we go to make a biopsy or to do that biopsy, we don't know the diagnosis. So what we are talking about is the appropriate technique, like we call it as an adequacy or inadequacy from the perspective of the diagnosis. But the real problem is not there. What we are talking about is a technique problem, like did I get an adequate sample at the time of procedure? So that is the gap we are trying to address. Yes, I can make a diagnosis of membranous even if there is a 1 Glom, but doesn't say that my procedure was adequate. Like my procedure was inadequate. Though I got 1 Glom, we made the diagnosis, we treated the patient, but still the procedure didn't achieve the outcome it was supposed to achieve. So that is the one message we are trying to convey, and we are trying to reach appropriate people who can make the difference in patient care, actually. So, Dr. Hastings, how are you going to approach a patient? Because this is going to be a very difficult conversation. Like, do you remember over your career you had that discussion? Like, how do you handle those conversations?
Well, I mean, I always prep patients before they do under a kidney biopsy. When we're discussing that in the office, I'd like to get the procedure. I'm hopeful that this will give us a definitive diagnosis. I'm hopeful that we can get prognostic information from the biopsy. But there's always a risk of us not getting the best kidney sample and not always being able to make as many conclusions from the specimen that we got as we would like to. Um, in the setting that it comes back that we do have a specimen that's inadequate and we can't answer questions about diagnosis and prognosis, I will tell the patient that, we probably need to go back and repeat this biopsy. I've talked to the radiologist, and here's how it's going to be different this time. Uh, this is why I think we can get a better sample and get us more information. Uh, and, I would never ever tell a patient that there was a mistake. It's not a mistake. It's just a risk of doing a biopsy that you might not get adequate tissue, and there are a lot of factors that go into that. Uh, but I think you have to have a plan of, what's going to be different if you go back and you send them for a repeat biopsy. Because we're very lucky at my center is that we have got a great relationship with our radiologists who do the biopsy. They are super easy to contact and talk to you, and how we can make the adjustments to see if we can get a better specimen out the second time around. And I think if you prep the patients before a biopsy and let them know this is not guaranteed. I hope that we're going to get a useful answer, but there's not a guarantee that we're going to get enough tissue. I think that makes them go into the procedure with a little bit more realistic expectation.
I think that is great. The cycling back with the patient of what you're going to do next and how it's going to be different, and having that feedback to the radiologist or whoever's doing the biopsy, I think is absolutely crucial. Do some of your patients give you pushback when you recommend to rebiopsy, and how does that go?
So nobody ever wants to go back and do a second biopsy. I mean, I can tell you 100% of the time, uh, if I talk to a patient, they're going to push back of that. How is it going to be different? It's not a fun procedure to put somebody through repeatedly. And even my patients who are going back, if it's a lupus patient that's had a flare, it's had a biopsy a couple of years earlier, for a patient, for example, we've got IgA patients with the new treatments available for IgA. There are people that are years out that we, have talked about rebiopsying. People remember that first biopsy if they don't necessarily want to do it again.
Like in a transplant setting, does your conversation vary if it is a for-cause biopsy, it's a protocol, or a surveillance biopsy? Like, is that your decision variable depending on the scenario?
I think it is. If it's a surveillance biopsy on a transplant and you don't get a good specimen, but everything else is going well, that may be a patient that you're not necessarily going to put them through another attempted biopsy. You may wait and do another surveillance biopsy 6 months, a year later, depending on what's going on. But yeah, that's a much less emergent situation than a patient that's got renal dysfunction or heavy proteinuria, and you need to get to the bottom of what's going on, so that you can plan treatment.
Yeah. Agreed.
What about the situation where, because there's sometimes you're looking for focal lesions, such as a proteinuric patient who may have FSGS. We've ruled out an immune complex mediated kidney disease or amyloidosis, but there's other things in the differential you could miss with a small sample, or an ANCA patient, for example, that might have acute tubular injury with red cell cast, and we could be missing focal lesions. If you make the clinical decision that not to redo a biopsy, is there a way that you counsel the patient that we don't have the whole picture and yet that's the path forward? And how do you handle that?
Yeah, I was the dreaded cannot rule out unsampled FSGS. We've all nephrologists have seen that on biopsy reports. I mean, I think you with that patient's history, you look at their blood work and their urine work, their urine studies and your imaging, and you put that together, and we can generally have a good idea when somebody's going in, whether it's a minimal change or whether it's a primary FSGS or a secondary FSGS, even if we don't necessarily get that information from the biopsy. The other thing that's helping us out these days is the rise of genetic testing. Um, so that's been extremely helpful. Like that somebody's got two high risk APOL1 alleles, that's may point you in a different direction um, in these biopsies. They're be coming back and you're concerned about unsingle disease. Likewise, if you've got somebody clinically that's got an ANCA associated vasculitis with severe kidney involvement, um, you're going to treat sometimes more based on what their renal function is, based on the percentage of crescents. It's nice to know, to have a good biopsy and to be able to have sufficient numbers to know percentages of crescents, but that's not the be all and end all. I mean, that's where we got to use our clinical expertise and take the information we've got, and move forward with that treatment plan.
So in ANCA specifically, suppose if you have 20 gloms on the biopsy, but still you were not able to find a crescent, will you be able to treat the patient clinically, or you won't treat the patient clinically because there were no crescents, but your suspicion is very high because that unsampled disease which we spoke about, it is possible to have that even with 20 gloms, right? So how do you handle that scenario?
If their C-ANCA titers are extremely high and they got significant renal dysfunction, I'm probably I'm gonna treat them for ANCA-associated glomerulonephritis. Sure. Again, so the biopsy is so important, and it's really nice to have that data, and it's nice to be able to get that data as a patient and say, look, here's what you got in the biopsy, and this disease is destroying your glomeruli, and this is why we're going to throw the kitchen sink at you. But again, you got to take the whole clinical picture of what's going on with that patient, along with what you see on that biopsy.
Sure.
Yeah, I'm sure that takes a lot of nuance and learning over time, and just shows your years of expertise in doing that, and that everyone's comfort level probably is different and presents quite a challenge. Um, when a patient has a single kidney, um, let's say the transplant scenario, or in the native setting where you only have one kidney and your risk may be a little bit higher to withstand bleeding or complications. Does that change your thoughts of biopsy?
We biopsy solitary transplant kidneys all the time,
Okay.
and have very low complication rates. So I think early in my career, if it was a solitary native kidney, I was very reluctant to send that patient for a kidney biopsy. But again, with experienced our experienced radiologists who do our kidney biopsies, our complication rates are low. And I think you talk for the risk. You talk about the risk to the patient of a biopsy with a solitary kidney, and you make a decision whether to move on. And we have been, we have very low complication rates with kidney biopsies at our center. We've got a very experienced team that does our biopsies, and we're very fortunate to have that.
Yeah. So, do you remember a case over your career, or if you heard about your case, can you walk me through that case, whether the rebiopsy helped you, or you might not have done a rebiopsy and you thought rebiopsy would have helped you in that case? So, do you remember any such case?
We had, I think that the case that I recall is, in the pediatric world where you got a child that's got steroid resistant nephrotic syndrome. And generally in children, I mean, we assume we actually don't biopsy all of our nephrotics that are for young children because the assumption is that they are minimal change disease and that you
Mhm.
would get a normal kidney biopsy. But in our patients that are steroid resistant, uh, you know, we sometimes don't know, well, are they truly steroid resistant or maybe they're not getting their medications the way we think they're getting their medications. Um, you know, and that I think those are situations where you might get an initial biopsy that may be read out as a minimal change. Or if it's an inadequate biopsy, I have gone ahead and rebiopsied, sometimes not immediately, um, but I've pushed on to get that second biopsy. And again, this is another situation where that the last case that I did that was several years ago, and I think now again, genetics help us a little bit with that. If we know they've got a specific mutation that would be more associated with primary disease or primary FSGS.
Do you often do genetics before biopsy or after? As far as does it help you forego a biopsy in some circumstances, provide ancillary information? How do you use it?
Um, in the last year or two, we've actually been using genetic testing a lot more. And so it's just another piece of the puzzle. I have a hard time, even in the situation of membranous nephropathy, you've got a positive antibody, and there are people that are saying maybe you don't need a biopsy. Uh, Membranous in the situation of positive antibody testing, I still like to get that biopsy. I mean, I think it's just really nice to have and to know what the chronicity, for disease chronicity and uh, looking for prognostic information. I think it's very helpful.
Got it. So, Dr. Hastings, if a fellow walks to you and asks you, like, tell me about biopsy adequacy and sampling limitations on day one, what is one rule of thumb you would give to that particular fellow?
I do think you go ahead and you quote off the numbers. You know, I think for most of the time, you really would like have at least 10 glomeruli. You've got to get cortex. In an ideal world, you're trying to use the 16 gauge needle. I think you do make sure the fellow's aware of all those parameters uh, of kidney adequacy because those are the biopsies that you're going to be able to get the best information from and have confidence in what you're telling the patient. Oh, that's really important. But I think you also have to make sure the fellow's aware that there are parameters for adequacy, but there's generally no biopsy is useless, and you don't discard an inadequate biopsy, and there's still clinical information you can take, and you've got to take the entire patient. You've got to take the history, you've got to take your testing, your other imaging, and that biopsy information, and put it all together to provide quality care for your patient.
No, that's super helpful information. It seems like you have a good team of interventional radiologists performing these biopsies. As far as communication goes on biopsy adequacy, giving them feedback for the next time around, how do those conversations go? And what would you recommend to your fellow moving forward to make sure that they ensure adequate biopsies, even if they're outside of your practice in the future?
So our uh, radiologists have a really great system of assessing their adequacy. They actually look at all of the pathology reports and traditionally have distributed those reports among the radiologists with everybody's names on them, um, looking at the biopsies that were done and their adequacy and their complication rates. So, uh, they already know if we reach back to them and we're concerned about an inadequate biopsy, typically they already know the biopsy's inadequate. And I think that's such a great system that they've got in place. We've got one of our radiologists who has been very much a champion of the renal biopsy process, and he's just made it a part of their culture. He knows how important this procedure is, uh, and he teaches the procedure to his colleagues and kind of gives them feedback on their technique. And I think that's so important to get the radiologist. They have to be interested in the outcome of their procedure. And did you know did we get an adequate specimen, and what the complication rates were? And that has worked extremely. I mean, we have biopsies where we routinely are getting 25 to 50 gloms, and that's just incredible. I mean, that just gives us such a great information when we have these high quality biopsy specimens.
I agree. Your practice is very unique where the entire ownership is taken by the radiology department. And they are doing a great job. At biopsy, they have created a loop for the feedback. So they improve continuously and they have made sure everyone in the practice is on the same page. So, yes, I love that. This is a great example. So, Dr. Hastings, is there a question we should have asked today which we have not asked you? Or is there a topic which should have been discussed today which we have not discussed? Can you think of anything like that?
I mean, my only point is communication. The nice thing about our team is that we all know each other, and whether it's the radiologist, um, we have a great relationship with our pathologist, Arcana, and we can pick up the phone and we can communicate about what's going on with the patient. And that really generates a lot better care, whether it's, that patient, letting the pathology know about, or letting the radiologist know about the patient prior to the biopsy and let them know kind of what we're looking for. Um, Communicating with the pathologist about what the biopsy showed, and patient history. That's what really makes. I mean, it contributes to high quality patient care. And that's, I have the radiologist, I've got several of their phone numbers on speed dial. I can pick up, just call on their cell phone. They can call me on my cell phone. Uh, and, as far as when we're reaching out to pathology, I mean, I can call Arcana and somebody's trying to direct me to a pathologist who read the biopsy on that patient. And they're always willing to discuss those results and review. And that's just as a nephrologist, that really, really helps me to counsel my patients to develop these treatment plans and give them information about prognosis.
This is excellent. Communication is the key, as you said, for good practices and to be in the loop to improve oneself continuously. Tiffany, anything else?
No, I don't have any further questions, but I think you provide a great example for best practices and improvement. And it seems like you have a great organizational culture to allow for that, but others should emulate obtaining that feedback proactively, making your colleagues accountable as well, but receiving feedback from them and um, we would be all better off if that happened. Inadequate biopsies happen every day in our practice, and even if we're able to get a diagnosis, we want to give the best diagnosis possible. And as you mentioned, when you have 25, 50 gloms, we have no problem doing that, and that's good.
It's amazing, with the information that we can get when we have good samples at low complication rates. So it's very impressive.
Thank you so much, Dr. Hastings, for your insights today. I bet this will be very helpful for the other practitioners also. So I really appreciate your time today. Thank you.
Well, you're welcome. Thanks so much for the invitation to talk about this very important topic. Um, and hopefully we'll continue to push to getting much higher adequacy rates for our kidney biopsies.
Yes, definitely. It will need a collective effort from all of us.
We're grateful. Thank you, Dr. Hastings.